Okay, we're going to go ahead and get started. There's so much to cover, and we only have a short time, so we're just going to go ahead. Welcome, welcome, welcome. Thank you all so much for joining us this morning, talking about one of my absolute favorite topics. Just a quick reminder, everyone is on mute by default, and you can block your video. And the chat is enabled, and the recording will be recorded. Okay, let's go ahead and get started. So just very briefly, who am I? So my name is Dr. Tracy Grimsley Myers. I'm a licensed clinical social worker. I am a new substitute doctoral lecturer in the SEEK department. I'm a clinician, a clinical consultant, and advocate. Today, we're going to be discussing one of my absolute favorite topics. So I have my timer on so I can stay on point, but always, 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 if you'd like to continue the conversation, please seek me out and I would love to do so. So what are our learning objectives today? Very quickly, participants will learn techniques to create safe and open spaces for students and coworkers, might I add, and colleagues, to adequately consider their mental health and potentially seek support. Participants will receive resources to share with students and anyone in need of mental health treatment and/or support services. And I will gladly make my slides available after the presentation. So let's get started. Let's talk a little bit about mental health since the pandemic. This is a topic that has really been in the news. It's been on our minds lately. Definitely the pandemic affected mental health, but really I believe the pandemic showed a light upon mental health because these issues were always there, but because we were indoors, because we were secluded, it really helped us all to see that people were really struggling and in need of help. So what's happened since the pandemic? According to the World Health Organization, since the outbreak of the COVID-19 pandemic, anxiety and depression have increased by 25% around the world. From 2019 to 2021, many communities of color experienced a larger growth in suicide death rates compared to their white counterparts. And so we know some of the reasons for this. COVID hit Black and Brown communities and communities, other communities of color, other communities that are disadvantaged, other communities that are really marginalized, much harder than it hit white communities. And so it affected folks' income. People could no longer work in the grocery stores. People could no longer do those careers and jobs that really had to be done in person, right? And also, unfortunately, the death rates in the Black and Brown communities were much higher than others. People from lower income homes were more likely to have experienced high psychological stress during and since the pandemic. When I think about at the time I was working with a lot of young people, and the young people in my communities did not have safe outdoor spaces, right? So many people were able to go to the park. Many people were able to go to their porches and things of that nature. But those who were stuck inside in 1 and 2 bedroom apartments, right, with many generations, really had no room. I can't tell you how many couples broke up after the pandemic, just sick of each other, how many families were struggling, but particularly when you had no room to go anywhere, it really amplified folks' psychological distress. So what about some of the young people and the folks that we work with? Young adults ages 18 to 29 are more likely to have experienced high psychological distress since the pandemic. 67% of LGBTQ young people reported experiencing symptoms of anxiety. 54% of them reported experiencing symptoms of depression. And according to the Williams Institute, as many as 30% of LGBTQ youth ages 18 to 24 have at least one suicide attempt since the pandemic. So what's happening on our campuses? As many as 64% of students drop out of college because of mental health problems. 56% of students are significantly concerned with their ability to care for their mental health. It's the number one concern of parents for their school-age children. In some studies, as many as 75% of students who struggle with depression and anxiety are reluctant to seek help. So they're simply struggling on their own and never letting us know. The prevalence of depression among college students is as high as 41% in some studies. It's almost half of our college campuses. Very briefly, suicide and suicide risk. It's the number 3 leading cause of death in Americans aged 15 to 24. In 2021, as many as 13% of all students had considered suicide in 2021. LGBTQ youth are 4 times more likely to attempt suicide. We hear a lot about depression, and it's a term that I think, fortunately and unfortunately, is being used a lot. Unfortunately, it's being used as a very common kind of throwaway phrase, right? I had such a rough day, I'm so depressed, which of course is not what depression is. And so I really wanted to bring shine a quick light on the facts about about depression, right? So that we can see that it really is incredibly serious when left untreated. Untreated depression increases the risk of substance abuse, increases the risk of suicide, increases the risk of dementia as it changes brain functioning. There's an increased risk of cardiovascular disease, an increased risk of diabetes, memory loss, and it drastically affects the body's ability to heal and recover from illness. In fact, the CDC began listing depression during the pandemic as one of those comorbid factors that were going to greatly increase your drastic outcomes, if you developed COVID. And so it really is more serious, I think, than people take it in this day and age, because it's become such a commonly used word in our vernacular. The life expectancy of those with untreated mental health conditions can be decreased by as much as a decade. This is drastic, right? The current life expectancy is 76.1 years. However, the life expectancy of many folks of color is already decreased. So imagine Black and Indigenous males already have a life expectancy that's 10 to 14 years lower than the average. And to have untreated significant mental health conditions on top of that can take away another 10 years of their life. So are people going and getting mental health treatment? Unfortunately, the majority of folks in disenfranchised communities are not. Only 33% of Black Americans, 36% of Latinx Americans, and 40% of LGBTQ plus Americans will access mental health services this year, even though they really need them. So we've already seen what some of the negative consequences can be from having untreated mental health symptoms, and already see what it can do to your life expectancy. So now imagine all of these folks being in your classrooms, your colleagues as well, right? Because we're not leaving anyone out. Everyone, no one is being left out of this. Everyone can be affected. And so let's look at very quickly and briefly why. Why aren't people accessing services when they really need them? And especially in this day and age, we think everyone now seems to have access to insurance. There is the, what they like to term as Obamacare, the Affordable Care Act, all these things. So why are people still not accessing services? Everywhere you turn, you see information about 988, 211, but what's going on? So I want you to be aware of all of the major barriers of accessing mental health services, but we're going to target just a few of them that you can affect change in. The number one barrier is stigma. It still exists, right? And so in the intersection of folks that are already disenfranchised, right, already being discriminated against, to then add the thought of having a mental health concern can be overwhelming. I've had so many clients tell me, Miss, I know you're not telling me I'm crazy, right? Such a huge concern. I'm not crazy. Stigma is so important for us to continue to address. We're going to talk about some ways that we can do that, but it's still, and I need people to understand, it's still a big deal. People still don't want to be known as having a mental health concern. Distrust of the medical system, that hasn't ended. I know many times we like to just kind of put that in a neat box of the Tuskegee incident, but that is not all there is, right? Black babies are still dying at higher rates than white babies. And what we find statistically is if that Black baby has a Black pediatrician, their chances of surviving their first year of life increases exponentially, right? So it's still there. The oximeter readings, we have recently been told, right, that the more melanin in your finger, the less likely the oximeter is to accurately read your oxygen saturation. This isn't new news, however. This has been known for decades. So think about what that meant for Black and brown folk, right, during COVID, being sent home because of false readings and dying at home. Language, that's kind of a no-brainer, right? You need to be able to understand your treater, and they need to be able to understand you. Immigration concerns and legal status. That is a very real fear. If I go somewhere, are they going to report me? What's going to happen? When I worked and live in Jersey City, I worked in a community health center. ICE wanted to come into the community health center and access our rates. It was a federally qualified health center. We were a stopgap, right? We were the place that you're supposed to go and be safe, regardless of your ability to pay, regardless of your immigration status, regardless of anything. And they were even still trying to infiltrate records there. Lack of cultural competence in providers, people not understanding one another, people not understanding the special experiences of Black and brown folks, LGBTQ folks, disenfranchised communities, right? Which add such barriers, and it leads to people being over-diagnosed and over-hospitalized and over-medicated. So it is very real. Lack of access to specialty healthcare. Many communities doesn't exist. The waiting lists are months and months long to see psychiatrists. Cultural norms of using alternate coping mechanisms. This is one of my favorite because it is something that is often stigmatized within communities, right? People often come to me for consultation and say, I'm so frustrated. I have so many clients who said first they want to talk to their pastors before they consider putting their children on medication. First, they want to pray about it before they consider. They want to use herbal remedies. And in Western medicine, this is frowned upon, right? But it is a huge source of coping culturally in many of our communities and needs to be respected. Lack of information, simply not knowing. I cannot tell you how many people I work with who didn't realize that they were depressed, who didn't realize that they were anxious. I overthink things, right? Never linked it with anxiety. I barely have enough energy to make it through the day. I'm not sleeping. I can't think. My mind is foggy. I'm not remembering things. So many things. I'm just not enjoying life. I'm not enjoying things anymore. As soon as I come from work and feed my kids, I get in the bed. I don't open the curtains. All of these signs and symptoms rarely, in many communities, are being linked with depression. And unfortunately, even in your primary care physician's office, they're not being linked with depression. They're being treated as individual symptoms. Financial limitations, lack of insurance, underinsurance. Yes, Medicaid has been expanded. Yes, folks have Medicare. Yes, we now have the Affordable Care Act, but mental health is not covered in the same ways all the time as physical health. In many insurances, you still have to pay your deductible before your mental health coverage fully kicks in. That's not the same for your annual well child visit. That's not the same for your well woman visit, right? So there is not full parity. And many of my folks that are on Medicare that come for treatment can't afford the copays. So we look at how so many elderly folks are choosing between their medications and food, and now we're asking them to pay $30 and $40 copays to address mental health concerns. Misperceptions of mental illness. Thinking that if I'm telling you, right, you appear to be experiencing signs of depression, people really begin to become uncomfortable. People really equate mental illness, unfortunately, with the folks that we see that are on the street, that are talking to themselves, that are wandering, that clearly are not present, clearly are struggling in many ways. And that is, for many people, their perception of mental illness and what it is. And of course, misdiagnosis by medical providers. Again, because unfortunately, youth are often misdiagnosed. So many times they're depressed and anxious, but we're saying they're difficult, right? They're not doing their homework. They're not showing up in class. They're sleeping during class. They're not doing assignments, right? They're difficult to talk to. And so we like to label them with conduct disorders, right? With saying they're explosive, they're dangerous, they're difficult, when really many times they are suffering with depression and anxiety. So what can we do? Why are we here? The first thing, you're beginning today, right? Educate yourself on mental health facts. The more you know, the more comfortable you will be in having conversations. The more comfortable you'll be if someone approaches you. The more likely you will be to recognize some symptomology in your students and in your colleagues and in yourself. Provide mental health information to our students, right? This can be done in many ways. It can be written into your syllabus, right? Simply talking about feeling overwhelmed. If you feel overwhelmed, this is something you can do. You can come speak to me. These are resources, right? Really making it so that it is common language, it is easily accepted, and students feel more comfortable saying, I'm a little nervous. Right. So our BIPOC students, our LGBTQ students may already feel that the odds are stacked against them. It was a struggle in some cases just to get here. And many of the students that we work with and talk to feel like they don't even belong here in the first place. And so you simply providing a more welcoming space and letting them know that it's okay to ask questions. It's okay to feel overwhelmed. If you understand that and understand their perspective, they're going to be more likely to open up and share with you. Have things hanging in your classroom. Let it be more than just Mental Health Awareness Week, right? Let it become a part of your classroom and a part of your classroom culture. Foster an environment where mental health can be discussed, where people feel safe. You do that by addressing language and behaviors that endanger feelings of classroom safety, right? I know at 10 o'clock, there's going to be a wonderful discussion about how to do that, how to curb language, how to address it, and how to help students feel safer in the classroom. Because we also have to remember that so many of the students that we're talking about are coming from unsafe environments and don't feel generally welcome and accepted all the time here at John Jay. And that we cannot have, right? So if we are aware of that from the beginning, we can take the extra step of making sure our classrooms are truly safe spaces. Assume good intent. Let's not assume that the student that falls asleep, that the student that's tapping their foot, that the student that may have their camera off, maybe looking down at a phone, tapping a pen, looking around, missing lessons, missing assignments. Let's not just assume that they're not interested. Let's not just assume that they can't do the work anyway, right? Let's ask, see what's going on for them. And if you begin to lay that groundwork, right, from your syllabus on, from the things they see around the classroom, from the language that we're using, they'll be more likely to follow up with you. Don't ask just one time. If you see something, as they say in New York, if you see something, say something. Take a moment, because it is so difficult sometimes for students to approach you. That is a huge barrier often. So approach them. How you doing? I noticed you missed the class, right? Not in a way that you're coming down on them, not in a way that we're disciplining, but in a way that's saying, I'm concerned. Are you okay? Is there anything that you need? Something you don't understand? Anything that I can do, right? Don't be afraid to ask. If you see something that's concerning to you, don't be afraid to ask the student about it. There are so many students, and statistically, it's out there that simply asking a student makes a student feel seen, makes the student feel that you believe they matter and are important, and makes them more likely to feel like they belong, right? More likely to seek services and seek help, more likely to share with you what's happening. Encourage the development of community and connectedness in your courses. This is especially important on a campus like John Jay, where everyone is in motion and in transit, right? So everyone is constantly moving. Everyone is in and out and going to their individual homes and communities. Do what we can to develop community within at least your classroom, right? Getting folks to work together on assignments, adding some group work into your classes. Even if it's just a few minutes of turning to the person beside you and sharing one thing that you learned, reteaching something, that increases that spirit of community and connectedness that goes a very long way within our classrooms. So this is a big one. Become aware of your own biases. You have to be honest with yourself. We are a part of our communities. We share similar heritages. We share similar issues. The things that our students experience, many of us experience. Many of us come from the same communities as our students, right? So we have those biases. We don't want to be seen as crazy either, right? Some of us may believe that someone on mental health medication is crazy. Be honest with yourself. Be honest. I would never take medication. I would never tell somebody my business. So I would never go to therapy. Be honest with yourself and the biases that you hold. That is a huge step in being able to connect with your colleagues and students that are needing services or that are just having a difficult time, right? Just be honest. Don't brush past it. Give yourself a minute and really become a little more reflective and introspective on the things that you believe you were brought up believing, the myths that you're brought up believing, right? Examine those because they're very important and they can stand in your way of seeing other people, and also they can stand in your way of reaching out to a student that or a colleague that may be in need. Weave well-being practices into your coursework. I know many times when we think about all the things that have to be put in there in that time period, we might say, how can I add one more thing? But schools and colleges and universities around the country are doing this. They're adding and weaving in 1 to 2 minutes of mindfulness, right? If you don't know how to do it, you can download a video. Videos are free, right? You can take a minute to just help you and students reorient themselves to the space. Came rushing in off the train, running in from getting coffee. You're running from another class to get in and start the day. You're already not present because you are already thinking about what you are teaching and what you are sharing, right? Everyone would benefit from reorienting themselves to the space. Taking that moment, recognizing where you are, grounding yourself, experiencing the feeling of the chair under you, experiencing the feeling of the floor underneath your feet, doing that quick breath, right? Just take a moment. Beginning or ending with a brief check-in. How is everybody doing, right? Allowing folks to speak, you sharing how you are and how you're doing. You can end the class or begin a class that way, or even both. Do things like offer extra credit for students to complete exercises, right? Such as a reflection on their concerns about your class or school in general, attending a student activity or group. Again, encouraging that connectedness, that community mindedness, and pushing them this a little. Sometimes the students need a little push to join, right? To participate in things. And that quick reflection may teach you a lot about what students are not sharing and what they're not telling you. They don't necessarily, it can be anonymous, right? It still will help you do a temperature check for your classroom and spaces. Watch your speech. This is huge, and this goes a long way in reducing stigma. There are so many words we carelessly throw around, right? When I listen to people just talking, their use of things like, he must be bipolar. 1 minute he's this, 1 minute he's that. You're crazy. She's crazy. Must not have taken her medication today. Those things so easily flow out of our mouths sometimes. We must be more intentional on what we say and how we say it. It is incredibly, incredibly important and has to be looked at, because if you are speaking this way, you're creating an unsafe space. If I'm a student in your classroom, if I'm your colleague, and I'm hearing you refer to someone as crazy, I'm hearing you flippantly use words like bipolar and she's off her medication and, she escaped from the hospital. How could I feel comfortable speaking and sharing with you, right? Share your pronouns and ask students their preferred pronouns and names and use them. Let's stop assuming. Let's really take a moment to help students feel more comfortable being who they are in the current space, and let's not assume. It's a dangerous, dangerous, dangerous thing to do, and it's not what you want, okay? I'm going to share resources, and I also want to remind you When you are giving a student or a colleague a resource, think about some of what we spoke about today, right? Think about some of the barriers that are occurring. Sometimes it may be helpful to take a minute and try a chat line, go to a website, call a number before you share it, right? So that you're better able to let a student or colleague know what's going to happen when they call. So just blindly sharing things doesn't work. And it's been proven that it doesn't work because people are very concerned about what they're going to be greeted with on the other side. What's going to happen when I call this number? What are they going to expect of me? What are they going to ask me? Right? Many times when folks are new to therapy and they're speaking with me, they say, I don't know how to do this. I don't know what to expect. Right? And so it is important to get some of that information. When you are referred to a treatment center, when you're referred to therapy, you will need to do an intake, right? You will need to know, how long will I have to wait for services? Encourage people to ask that, or find that out for yourself before you offer it. As we said, many counseling services, unfortunately, have been inundated, right, with people since the pandemic seeking treatment and have waiting lists that can be as much as 6 months long. It's also important to point out that many of our students are interested in joining the armed forces. Many of our students are interested in joining NYPD, the fire department. When you begin treatment and insurance is involved, that does become a trail. Students that tell you, I'm very afraid of joining formal counseling, it's a legitimate concern. Even our counseling services center, which does have a waiting list, right, at John Jay, if you are interested in joining the NYPD, they're going to ask for that release of information for the counseling center. So no one can provide personal information due to HIPAA, right, and your protections. However, they're going to ask for it. They're going to ask you to release the information to them. Insurance does follow you. Your diagnosis can follow you. So these are real concerns. So this is why some of the anonymous sites can become more popular with students and colleagues, because people don't want things to follow them. And we have to take that into consideration. It is real. 988, that's our crisis and suicide hotline. It's 24/7. The counselors that answer the phones are trained. The person in crisis or the person who needs to talk can call and text. The person who is concerned for someone else can also talk and text. Please be aware, studies have recently been done that still BIPOC communities, disenfranchised communities, LGBTQ communities have still been hesitant to use 988. Why? Because many of them do believe that the police are going to be called, right? So if I call 988 and I say, I'm struggling, people are worried that the police are going to be called. This is still very real. Unfortunately, a very dear friend of mine lost in Jersey City, lost just a few months ago, her family member, well known within the community, never disruptive, never harmed anyone, right? Known to the police, experiencing a schizophrenic episode, right? But well known and known to be diagnosed with schizophrenia. The family asked for a wellness check because they had not heard. He stopped answering the phone and he hadn't been seen outside. He didn't answer the door. The police forcefully entered his home. He became scared. not knowing who was entering his home, right? And not being completely clear anyway. But how many of us would not be terrified if their doors were suddenly pushed in, right? He grabbed something to swing and he was killed by the police from a wellness check. This is still very, very real. It's a very real fear. What I will say and encourage you to also share, if you want to share 988, it is not common at all for 988 to contact the police. It is not at all common. Most of over 90% of the folks that do access the services, never 911 is not called. It's called when they're afraid that you're about to harm yourself or harm someone else, which of course is when we call 911. So I think it is important to know that there is a hesitancy in using 988. And so if you could just speak to that and really explain what 988 does, there's a fact sheet, happily to share the fact sheet. It can go a long way. These are some of the other services that are very important and are specific to certain populations, because that is incredibly important for people, right? To make sure that the chances are better when they reach out to one of these resources, they're going to be understood, that they're not going to have to be explaining the nature of just who they are as a person, right? So things such as the Trevor Project. The Trevor Project is a wonderful, wonderful resource. If you go on it, one of the great things I love, right? It specializes in services and support for the LGBTQ community and those who love them and allies and support them, right? You go on the website, the first thing that pops up is an explanation of how to quickly leave the website in one stroke if you feel uncomfortable because someone walks in the room or someone is looking over your shoulder. That is very real. And these are the type of things that I said, this is why it's important for us to kind of vet some of these services, some of these resources prior to just blindly handing them out. That simple fact may help somebody to feel more comfortable in accessing services. So NAMI Mental Health College Guide, it's a great resource. National Association on Mental Illness, it's a great resource. It's great to have on hand to share with students. Trans Life Hotline, these things run 24/7. People can call from their cell phones, they can have private conversations, and it's really, really helpful because, again, many times they are community specific, and that will encourage students and colleagues to feel more comfortable. So many times people are saying they're having difficulty as a person of color finding, or a person within the LGBTQ plus community finding clinicians that look like them, right? Finding clinicians that understand, finding clinicians that have similar experiences. So these are all wonderful, wonderful websites that are specific, right, in meeting cultural needs, in meeting needs of sexual orientation, identity, similar situations and specialties such as being a veteran, right? Because that is a specialty. So these are wonderful, wonderful resources. I will tell you, it is not always that in these resources that folks are LGBTQ plus, that folks are Black, that folks are Latinx. They also may have wonderful, wonderful training experiences and be allies, right? And be vetted safe spaces. I love especially things like Institute for Muslim Mental Health. Many times some of this stuff is left off, right? We concentrate on certain blocks of people when we're considering things, but there are so many disenfranchised communities, so many cultures where therapy and mental health treatment have not been supported, right? That's so common also in many religious communities. I've had so many folks from BIPOC communities who actually believe that depression and anxiety are symptoms of weakness, right? Are symptoms of spiritual weakness. If I prayed harder, I wouldn't be depressed. If I studied the Quran harder, I wouldn't be depressed. There's something I'm doing wrong that I'm depressed, that I'm anxious, right? So helping people to understand that there is room for your faith and room for mental health treatment is incredibly, incredibly important. And that is a very high in the BIPOC community. So that is also something that needs to be understood and respected because it is a huge, huge barrier. I did, for my dissertation, one of the studies I did was working with the leaders of houses of worship, because so many times in the BIPOC community, they're the first line of defense for mental health treatment, right? People go to their pastors, people go to their imams when they are experiencing some type of mental health crisis or they're concerned. The majority of the research shows, and the people that I worked with show, they don't feel equipped and are not equipped to handle this. And that's incredibly, incredibly important. Not all of the leaders in the house of worship wanted to admit to their congregants that they did not feel equipped to help them if they were having a mental health crisis, right? And so it is not necessarily something that is being taught within the seminaries and other educational systems. Many times it's one class, if that. So to really begin working with some of the houses of worship for treatment providers is very important. And I wanted to point that out because it is huge in the BIPOC community. Do we have any questions? We do have time. I wanted to give people an opportunity to ask, to share something, anything that you may be interested in. You can put it in the chat or you can unmute. Anything at all? If you do come up with something later or did not particularly want to share in front of everyone, please feel free to reach out to me. I want to, provide myself as a resource. This is a topic that's near and dear to my heart. It's a part of my research, is a part of what I teach and share because it is mental health within BIPOC communities, disenfranchised communities is an incredible, incredible concern. And people, as we saw in the beginning, still are not accessing treatment and resources. And so I'm here to provide that and provide that help for you. So next up, there are breakout sessions. The next up, Bright Space with Coffee from 10:15 to 11 a.m. in person in the Moot Court. Please feel free to post any screenshots, insights, or anything at all that you wanted to share today on Instagram and Twitter. And you will be able to receive a copy of the recording. And I'm also going to make my slides available so that you have the resources available to you. Thank you.
Dr. Myers, I did see we had a question in the chat from Rocio.
Okay, beautiful. Let's see. I'm going to stop share so that I can better be able to see. the chat. Okay. How can we deal with students that disappear and come back at the end of the semester telling that they had a mental health problem? Wonderful question, because many students came to me at the end of last semester and said, I went MIA, right? And so if we remember something that I spoke about in the beginning, right? Sharing and creating that safe space for students in the beginning. And when you notice that a student has missed a couple of classes in a row, when you notice that they've missed a couple of assignments, check in with them, right? Yes, they do not necessarily pick up emails. Trust me, I know. They're not necessarily going to answer their phones. Trust me, I know. But make the effort, right? Make the effort. And if you are concerned about a student, you can contact the John Jay Counseling Center and discuss with someone there what to do and how to do it. So I want you to know that that is a resource that's available to you. But unfortunately, at the end of the semester, right? That's very hard because you've missed the entire semester. That is a consequence that the students will have to deal with, but still have the discussion, still make the referrals, still talk to them about withdrawing, still talk to them about retaking the class, talk to them about the supports that are available that may have helped them, that will help them next time. Let's see, are there any more questions? I'm so glad you found it helpful. I'm glad you enjoyed that. Yes, I see someone is saying, I agree, group work is very important in the class. Many students state getting help for mental illness is against their culture. Absolutely, it's outside of the norm. And many times, our families don't support it necessarily. Many of our students are more willing than their families allow them to be, right? And so that has to be understood and taken into account as well. So normalizing all of this is the best way, and respecting people's cultures, letting them know they understand. I understand that your family is not comfortable with this. I understand it's not done in your country of origin. I understand that it's not accepted in your family of origin. I understand. And you may still find it helpful, right? Don't stop the conversation just because someone says, oh, that's not really something that we do. Be brave, push a little bit, talk a little bit more. Are there any other questions or comments?
Hi, Dr. Myers.
Good morning.
Morning. So I just would like to know your thoughts about, you mentioned in your resources the anonymous kinds of counseling and therapy interventions. And your thoughts about, or any experience you have with those, or people utilizing them, and I guess the risks and benefits of, people accessing sources that may or may not provide them with a specific person or connection. Any thoughts or experiences you have?
Yes, I think that they're a wonderful resource, because for some people, it is the only way they're going to be willing to access a service, right? Some folks just need to be heard and need to be listened to. And the people on the other end of the lines are fully trained to do that and provide support. So while it may be a one and done kind of thing, they're still going to receive that support. They're still going to be heard. They're still going to have connection, right? Because remember, in this day and age, our students they don't particularly care for face-to-face as much as we did, right? So being able to text and get that's really popular with some of my younger clients. Being able to text questions, text and ask support, text and be connected with someone, it's still a very big deal. So they still will receive resources, they still are invited back to that original resource themselves, that original site that they accessed. So I would say that they are not, there really aren't too many risks in using it, right? So even if someone is suicidal, I would prefer them to contact an anonymous source and get some support than to keep it to themselves. These are also great because the folks that love you are able to access them and say, what do I do? What can I say? How can I connect the person I'm concerned about?
Okay, thank you. That's
Thank
helpful.
you. Yes.
Hi. How's it go? So I have a question. So in your personal experience with dealing with your young clients and also based on research, do you think therapy could go a long way?
Oh my goodness, it can be life altering. Life altering. And many times it doesn't take long, right? So people think we're not, in this day and age, we're not laying across the couch and talking about when my earliest memory at 3 all the time, right? Many times it is brief. Many times we just need to learn tools to use. We just need to know how to deal with anxiety. What happens when I'm having a panic attack? What can I do? What are the thoughts and what are my beliefs that I'm having that feed into this, that keep this going? Just increasing our understanding of what we experience goes an incredibly long way. Life-changing.
Thank you.
Thank you for your questions. Thank you. Do we have any other questions? I want to thank you for all the kind words you've shared in the chat. I'm really appreciative that you found this helpful in any way at all. And please feel free to reach out to me if you want to continue the conversation, if you have concerns, if there are things you just want to know more about. I'll be happy to talk with you, point you in the right direction. Absolutely being intentional with what we say. And how we say it. Words have meaning and they can harm others more than we expect. Absolutely. Thank you for sharing. Is someone asking me? Yep. Let me put my email in the chat for you. Oops. And why is it not populating? I'm scrolling. I'm not sure why it's not allowing me to enter the chat. But I'm at T Myers, TMEYERS, at johnj.cuny.edu. Thank you.
Yes. Thank you for the wonderful presentation.
Thank you so much. I hope you guys have a wonderful day with lots of learning and sharing and connectivity.
Thank you. This is great.
Thank you so much. Take good care.
You too.
Thank you.
Thank you.
Thank you.
Thank you so much.